Good evening, everyone. It's a wonderful opportunity for me to present before you a clinical case on breast. I am J. Hariharan from 2017 batch studying in KFB Government Medical College, Trichy. Today, I am going to be presenting before you a clinical case on breast history. A 52-year-old postmenopausal female patient named Kamala came from Musiri, Trichy. She is a homemaker by occupation and comes from a family of low socio-economic status. She presented to the OPD with complaints of a lump in her left breast. Chief complaints, a lump in her left breast for the past 6 months. History of presenting illness. The patient was apparently normal before 6 months, and then she developed a lump in her left breast, which was insidious in concept. Its size was initially 2 cross 2 centimeters, which rapidly progressed to 10 cross 10 centimeters. It was initially painless, but since the last 2 months, the patient complains of a dull aching pain, which is relieved by medication. History of presenting illness, history of ulceration for the past 2 months. It is associated with foul-smelling discharge. The ulcer progressively increased in size to the present 7 cross 5 centimeters over the breast lump. No history of discharge from the nipple. No history of retraction of nipple. No history of loss of weight, appetite. No history of hemoptysis, breathlessness, bone pain, jaundice, headache or seizure. That is no history of registry of malignancy. No history of bowel or bladder disturbances. No history of intake of oral contraceptive pills.
Continue, man. Just complete your history taking, man, first. Then we will discuss about history taking. Complete the history taking.
Medical and surgical history. No history of diabetes mellitus, tuberculosis, hypertension or epilepsy. No history of any previous surgery. No history of irradiation for any other illness. Personal history. No history of any addictions. The patient is on mixed diet. Menstrual and marital history. She attained her menarche at the age of 12 years. She attained her menopause 5 years back. At the age of 47 years, she is happily married for the past 30 years and has 2 children. She breastfed both her children till the age of 6 months. Her obstetric score is P2L2. She had her last childbirth 25 years back. Family history, no history of breast, ovarian or colorectal malignancies among her first degree relatives. So history is over, sir.
Okay, man. Yeah, the session will be like a discussion session, man. Okay. I won't be asking you much questions. We will discuss about the possible questions that can be asked. Okay. Because asking questions simply won't be useful for you people. So I'll just tell you the possible questions that can be asked, man. So go to the first slide, man.
Okay. Yes, sir.
Okay, here. What is the importance of age? Can you just, can you just tell me the importance of the age of the patient, man?
Sir, the breast cancer has greater propensity, or the probability for getting breast cancer rises with increase in age. So, greater than 50 to 60 years of age, the patient could have breast cancer in a greater frequency.
Incidence of breast cancer.
Regarding
Incidence of breast cancer. Yeah, yes, man. Continue, please.
Regarding menopause, since the patient is a post-menopausal woman, so the chances for breast cancer, which is hormone-negative breast cancer, can also arise. Along with the age, the post-menopausal features also indicate.
Okay, man. From the age, what we can infer is that if the age is more than 50, if the patient is elderly patient, the mass can be most likely a malignancy than a benign lesion. Okay, and if a patient presents in a younger age, we should rule out other tumors because in younger age it can be due to a hereditary lesion. Some chromosomal abnormality can be there, like BRCA1 mutation or BRCA2 mutation. HER2 mutation is more common in younger age group. If a younger age group female presenting with the mass in breast, we should rule out other masses, other tumors, like any GA malignancy, any melanomas are there or not. Okay, so age of the patient is more important to determine whether it is a benign, it is more likely to be a benign lesion or a malignant lesion. In case of elderly people, it is more likely to be a malignant lesion, and in case of younger people, it is more likely to be a benign lesion unless until there is a positive family history or genetic predisposition is there. Okay, so then what is the importance of the location of the patient, man? I mean, a place of living. In which countries it is more common? CA breast.
It is more common in Western countries.
It is
In
more common in
developed
the Western countries than other countries. The reason given for this is that they are nutritionally very, they have high nutrition status. So their estrogen levels are also very normal, or even sometimes they have higher estrogen concentration in their body. This can lead to CA.
Yes, sir.
This is a reason given for it. Okay. Then what is the importance of socioeconomic status, man? The importance of socioeconomic status. Okay, there are two important things in socioeconomic status, man. CA breast is more common among high socioeconomic status people. Okay. In what way the low socioeconomic status affects CA breast is that it will affect the treatment process. Treatment of CA breast is not just simple issue. Okay. It involves radiotherapy, chemotherapy, and surgery. So the compliance of patient is more important in curing of the disease. So low socioeconomic status of the patient can affect the compliance of the patient and can lead to morbidity and mortality. But CA breast is more common among high socioeconomic status. Okay. So next.
Okay, sir.
So the complaints. So coming up to the chief complaint. Okay. Yeah, the duration is more important, man. Usually, it will be a chronic lesion. The malignant lesions will always be a chronic lesion. In case of benign lesion, it may be of short duration. Okay.
Okay, sir.
What are the other complaints it can be? What other complaints the patient can present with, man? Other than lump. Other than lump, the patient can present with nipple discharge alone. Or
bleeding, sir. Bleeding per
bleeding. Nipple discharge alone can be a complaint, or pain alone can be a complaint. With ulcer alone can also be a complaint. Okay, but most common chief complaint with which the patient presents is lump in the breast with chronic, with the chronicity. Okay, next slide, man.
Okay.
So here we are explaining about the lesion. Okay, as usual, how we will explain the swelling, you have to explain about the lesion. Okay, so here instead of giving the size of lesion, because here it should be of patient's word, so we can't. The patient won't tell about the size. It is around 2x2, it's 10x10. So you have to compare it with some adjective, like a peanut-shaped swelling or a hemispherical swelling. This is how the patient will be explained, man. Okay, and how she noticed it. Initially small in size, and then it grown rapidly. Rapidly means how, within which duration, within how many months it had increased in size. It should be that. Okay. Within how many months, or within which duration the size of the swelling increased. The swelling may be static. Size of the swelling can be static for a few months, and it may have a rapid growth within last 10 days or within last 5 days. That this is indication for malignant transformation of the benign lesion. Usually the lesion will be painless. Okay. What are the causes of malignancy leading to pain, man? Usually the malignant mass will be painless. Okay. When the malignant lesion can become painful?
When there is infiltration of the deeper structures.
Okay. Any nerve or any deeper structure, adjacent structures, then?
If there
any
is
superadded infection.
Yeah,
superadded infection can also lead to pain. Okay. So next slide, man. So here, coming up to the pain over the breast, the most important thing is that you should relate the pain in the lesion with the menstrual history. If the patient is a if the patient is a premenopausal woman or menstruating woman,
Okay, sir.
the pain in the breast should be related to the menstrual cycle.
Okay, sir.
Okay. So coming to the next history, here is a history of ulceration, and to explain the ulcer, here too you have to tell about how it had started, whether it started as a nodule which ulcerated, or whether it was a blister that ulcerated. Okay.
Okay, sir.
And then foul smelling
Okay.
discharge is there. Here you mentioned about the smell of the discharge, but the nature of the discharge should also be mentioned here, and the color of the discharge is also more important. Whether it is a
Okay.
red color, whether it is a bloody discharge. In what conditions you can get the bloody discharge, man? In what conditions we can get a bloody discharge from the nipple? Nipple
Sir,
discharge.
sir. Hello, sir.
Carcinoma.
Sollu thambi.
Sir, some of them answering in chat section also, sir.
Wow, super, yeah. Nice. கண்டிப்பா சார், நான் அதுவும் பார்க்குறேன் தம்பி, கண்டிப்பா பார்க்குறேன் அந்த மெசேஜஸும். ஓகே,
அது கொஞ்சம் பார்த்துங்க சார், ஏன்னா அவங்க ஆன்சர். ஓகே சார்.
Sure.
ஓகே சார், thank you sir.
Okay. So ulceration, you mean here is that there is a skin involvement, man. That is the meaning of
Yes,
this,
sir.
okay?
Yes, sir.
But there can also be a secondary ulceration which is not related to tumor even.
Okay, sir.
Here in our country, the patients can go for some native treatments which can lead to ulceration. Okay. So while taking a history of ulcer, the onset of ulcer is more important, whether it started from a nodule or it started as a blister, how it has started, and the nature of discharge, foul smelling, pus discharge or serous discharge is more important. Okay.
Okay, sir.
So that's a new history of discharge from nipple. So what are the conditions that lead to nipple discharge? It's being answered by many people. Like duct papilloma is a cause for bloody discharge. And what is the cause for greenish discharge from the nipple, man?
Due to an
Actually, he has answered. Please answer, man. I can't get you.
Sir, due to an infection like abscess formation within the breast.
Greenish discharge from nipple.
Greenish discharge. Don't know, sir.
It is due to duct ectasia, man. Most common cause for greenish discharge from duct ectasia. And other rare condition is that any breast abscess due to pseudomonas can also produce greenish discharge. Breast abscess draining inside the duct. Okay. So the history of retraction of nipple. What is the mechanism behind the retraction of nipple, man? Mechanism behind the retraction of nipple. Usually, the nipple retraction is due to infiltration of the fibrous tract. Okay. A ligament of the breast contour is maintained by many ligaments, man. Cooper's ligament and other ligaments. Okay. The infiltration of the fibrous tract and the Cooper's ligament will lead to retraction of nipple. So yesterday we saw about 2 types of nipple retraction. What are the types of nipple retraction? Types of nipple retraction. Usually it is of 2 types, circumferential and radial. Radial also called as segmental types. Segmental, okay. Or slit-like.
Okay.
So which is common in malignancy, which is more common in congenital nipple retraction can be which type, man? Congenital nipple retraction will be usually circumferential. Udayalakshmi has answered it correctly. Congenital nipple retraction will be circumferential. Okay. This can be corrected by using a suction effect with a syringe. And usually the nipple retraction due to malignancy will be a radial or slit-like retraction will be there, and there will be a history of recent nipple retraction. Okay, history of recent nipple retraction. Okay, you can also change it as a no history of recent nipple retraction. Okay, recent can be added. Okay, and what is the importance of weight loss and loss of appetite, man?
The cancer, cachexia, the
Yeah, any
malignancy.
CA will lead to a catabolic state. Okay, we have two type of state in our body metabolism: anabolic metabolism and catabolic mechanism. Sorry, metabolisms. Any cancers can lead to catabolism. This will lead to cachexia. This is called as cancer cachexia. There will be loss of weight and loss of appetite. Okay, next slide.
Okay, sir. Hemoptysis.
Yeah. What is the importance of hemoptysis, breathlessness?
Sir, metastasis to the lung.
Which part of the lung, man, can produce hemoptysis? Pleura or parenchyma or bronchus or trachea? Which part invasion can cause hemoptysis?
Sir,
Usually lung parenchymal involvement, man. Lung parenchymal metastasis can present as hemoptysis. Breathlessness can be due to any involvement. Even pleura involvement can lead to pleuritis and breathlessness. And lung nodular and lung parenchymal involvement can also cause breathlessness. Okay, bone pain. Okay, this is due to most common symptom of bony metastasis will be in CA breast, man. In CA breast,
bone tenderness, sir.
Yes, man. Which part, which bone? Usually, our lumbar vertebra will be affected. Lumbar vertebra, lower back pain is the most common symptom. Okay, this is due to why the lumbar vertebra is more commonly affected. I think I have answered it correctly. That is Batten's plexus, not Batten's. Batten's plexus. Most common site of bone metastasis is lumbar vertebra. This is due to Batten's plexus that are direct communication. Okay. And then jaundice. Jaundice is due to liver metastasis. Okay. And headache or seizures can be due to brain metastasis. And other signs of ICT can also occur in brain metastasis. What are the signs of increased intracranial tension, man? What are the signs of
blurred vision?
Okay.
So vomiting, projectile vomiting.
Yeah, projectile vomiting and the seizures. Okay. There will be no nausea. Okay. Someone have answered as nausea and vomiting. There will be no nausea. There will be projectile vomiting. Okay.
Okay.
Okay. The importance of bowel and bladder habits, bladder disturbances in this patient, man. You have stated that there is no history of bowel and bladder disturbances. What it means? Why you have stated it here?
Sure.
No issues, man.
Suppose if there are secondaries to the pouch of Douglas, then
nice.
There could be a bowel disturbance.
Bowel disturbance can be there. There can be even some colorectal malignancies. Other colorectal malignancies can also be there in case of any genetically induced tumor, hereditary tumors. And other thing is that Krukenberg's tumor, as answered by Bharati and AR. Okay, Krukenberg's tumor can also present as a abdominal pelvic mass even. Okay. So what is the importance of oral contraceptive pills, man?
Sir, it is a risk factor for the development of SCA, sir.
All oral contraceptive pills are they risk factors, or what content?
Sir, no, sir. Estrogen containing oral contraceptive pills, sir.
Okay. Then what other history can be asked here, man? Post-menopausal hormone replacement therapy can be also asked here, man. Okay.
Okay, sir.
History of post-menopausal hormone replacement therapy history can also be asked. Okay. Next slide, man.
Medical surgical history, sir.
History of diabetes, tuberculosis, hypertension, epilepsy are more important here. Why? What is the importance of this history in CA breast, man? It will affect the disease process and it will also affect the treatment protocol. For an uncontrolled diabetic patient, it cannot operate. Okay, we need to control the diabetes sugar level in the blood. Okay, so these are all the things that supports our surgeries. that will help in proper healing. Okay. So
Okay.
history of previous surgery. What is the importance of the history of previous surgery, man? History of previous surgery. Importance of history of previous surgery. If there is any history of previous lumpectomy from the breast, any history of lump removed, or any history of breast tumor removed, maybe even a benign tumor, that is more important in case of CA breast. Okay, because the CA breast can arise even from the scar tissue or residual mass that is left. Initially, patient may be wrongly diagnosed, or patient can have a lost day follow-up. Sometimes the benign disease can be a precursor disease, and it can lead to malignancy. So history of previous surgery is more important in this case. And then there is mentioned about a history of irradiation. What is the importance of irradiation, man?
Sir,
In what
exposure to
disease?
ionizing radiation at a younger age can increase risk of breast cancer.
What is the most common cause? In what disease you will advise or you will treat a disease?
Sir, thyroid, hyperthyroidism.
Okay. Okay, then what else, man? Most common thing is that mantle irradiation for lymphoma. Okay. Mantle irradiation for lymphoma, Hodgkin's lymphoma, as people answer here in the group. Induja Kannan, Uday Kumar. Lymphoma is the most common disease which is being treated by chest irradiation that can lead to CA breast. And approximate or average time taken for conversion after the radiation exposure is minimum of 10 years, man. Okay. This is given in a book, okay. So what is the importance of personal history? Importance of personal history.
Diet.
Importance of
The
alcohol
obese
intoxication.
women can synthesize greater amount of estrogen, thereby leading to a possibility for breast cancer.
Okay. Obese women are exposed for, obese women are higher risk for CA breast development. And what is the importance of alcohol? Whether alcohol consumption will help you or it will lead to CA breast?
It is a risk factor for breast cancer, sir. It is increasing the risk factor.
It increases the serum estradiol level, and it is, of course, will be a risk factor for developing CA breast. And what's the importance of diet? Whether any diet can help in preventing?
Sir, increase in antioxidants like vitamin C, beta carotene.
Of course, generalized protective effect will be there. Any specific things?
Reduction in the fat, saturated fat.
Someone asked that. Lakshmi answered about it. Phytoestrogen level. Okay. Increased intake of plant products that may contain phytoestrogen will have a negative feedback mechanism that thereby decreases our human estrogen level. Okay. When we are taking phytoestrogen in more amount, our body will recognize the presence of phytoestrogen, and by negative feedback mechanism, it will reduce the estrogen synthesis in our body. But the phytoestrogen will not act on our receptors. So, though you have two protective effects of phytoestrogen, man. Phytoestrogen will not act on our estrogen receptors, but it will mimic the estrogen, human estrogen. So, by negative feedback mechanism, our body will not produce estrogen. This is how the intake of phytoestrogen, plant products, will help in protecting us from the CA breast. Okay. Next slide.
Okay, sir.
So coming to most important thing of the history taking is menstrual marital history in CA breast, man. The single concept is that increased prolonged exposure to estrogen will lead to CA breast, will provoke CA breast. That is a single concept. Anything that causes increased exposure or prolonged exposure to CA breast will lead to, prolonged exposure to estrogen will lead to CA breast. So early menarche, if patient have got early menarche, she is being exposed to estrogen at a more level, okay. And similarly, late menopause, she'll be exposed to estrogen at more concentration. And if she is nulliparous, during pregnancy, the estrogen level will reduce and progesterone level will increase. Okay, but if the female does not get pregnant, she is being exposed to estrogen for a long time. And the short duration of cycle is also more important, man. You should have written about the
Okay, sir.
cycle duration. Okay. If some patients, some females may have 28-day cycle, some may have 20 days, even sometimes females can have 15-day cycle. If the cycle duration is very less, they are more prone for increased exposure to estrogen and CA breast. Okay. So how the breastfeeding helps in will have a protective effect, man? How the breastfeeding has a protective effect? What is the mechanism behind it?
The longer the duration for breastfeeding, greater will be
Nitisha
the
answered it well. So during breastfeeding, you will have prolactin synthesis, man.
prolactin secretion.
Yeah. Prolactin will suppress the estrogen production. Okay. This is how the breastfeeding has protective effect against CA breast. Okay. So
Okay, sir.
breastfeeding, duration of breastfeeding is more important, and number of child she has breastfed is more important. Okay. You have more than
Okay,
writing an
sir.
off-stage score. You should have written the menstrual history and marital history separately. In menstrual history, you should write about the age of menarche and LMP, last menstrual period, and the duration of cycle, and about the pain, whether menorrhagia is present or dysmenorrhea is present. What is the importance of dysmenorrhea, man? Usually, prostaglandins will cause muscle contraction and pain. Okay.
Okay, sir.
So this means that prostaglandins will. Okay. So next question, next slide, man. So family history. Family history is more important, man. Okay. Because family history, if you go to for BRCA1 and BRCA2 mutation and HER2 mutation, and the history of breast cancer, ovarian, colorectal malignancy should be noted. Okay. If any positive family history is there, the patient should be kept on monitoring. Okay. If patient has, if any female around 20 years or 21 years coming with the complaints of lump in the breast or pain in the breast, if the patient complains, patient has no mass palpable clinically, but still the patient complains of mass or a lumpy feeling in the breast or a heaviness of the breast, she should be kept under continuous monitoring. Screening should be done every 6 months because she has positive family history. Okay.
Okay,
Next
sir.
slide.
Sir, examination.
Okay. So before this, you have to write a summary of the history, man. From the history, you should come out with a diagnosis. Okay. From the history, you should go for a proximal. You should go for a provisional diagnosis, and then you should go for our general examination. Okay.
Sir.
Okay, sir.
Okay. சொல்லுங்க தம்பி.
சார் இம்பார்ட்டன்ஸ் ஆஃப் டிஸ்மெனரியா யாருக்குமே வந்து கேட்கல, ஆடியோ கிளியரா கேட்கல, அதை இன்னொரு டைம் ரிப்பீட் பண்ண சொல்றாங்க சார்.
சரி, நான் லாஸ்டா சொல்றேன் தம்பி, கடைசியா சொல்லவா? முடிச்சிட்டு.
ஓகே சார், ஃபைன் சார். ஓகே சார்.
ஜெனரல் எக்ஸாமினேஷன் ஸ்டார்ட் பண்ணுங்க தம்பி.
Okay, sir. So, a general examination, she is a moderately built and nourished. She is conscious, cooperative, and oriented to time, place, and person. No pallor, no icterus, no pedal edema, no cyanosis, no clubbing, no generalized lymphadenopathy. Vitals, pulse 84 per minute, blood pressure 124/80 mmHg, respiratory rate 17 per minute. Patient was afebrile.
Okay, next man.
The local
exam. So what the importance of general examination in CA breast? What is the importance of general examination in CA breast? Patient will be cachectic, man. In case of advanced disease, patient will be cachectic. Okay, she will be thin-built, malnourished. Okay, she will be pale, and in case of liver involvement or liver metastasis, there may be a patient may present with icterus. In case of any lymphovascular, axillary lymph node involvement or lymphatic involvement, patient can present with lymphedema of the legs, and then maybe even lymphadenopathy if lymph nodes are involved. Okay. So general examination is more important to determine the early resuscitation of the patient. Okay. So for early resuscitation of the patient, general examination is more important. Our treatment should never main aim of the treatment for CA breast is the elimination of the disease. But resuscitation of the patient with the necessary needs is also more important. If the patient is cachectic, nutritional resuscitation should be done. Nutrition of the patient should be improved because
Okay, sir.
surgery itself is a stress for this patient. Okay, it will lead to physiological stress. So before going for any surgery or any procedure, we should improve the general condition of the patient and then we should go for a definitive procedure. Only after improving the general condition, you should go for definitive procedure. This will give a better outcome of the surgery. Rather than going for surgery itself, you should improve the general condition of the patient. So general examination is more important. Okay, next slide. Next slide, sir. Next.
Oh.
Next.
Okay.
Yeah,
Local
continue.
examination. Local examination, first inspection. The inspection was performed when the patient was kept in sitting posture. First inspected part was the breast. So the position was normal on right side. On the left side also it was normal. No, not displaced in any direction. Size and shape of the breast was slightly elevated in the left side in comparison to the right side. An ulceroproliferative growth was present in the upper outer quadrant of the size of 10 cross 10 centimeters, just above the lump. It is 7 cross 7 centimeters, so there is a mistake here.
Okay.
Dimpling was absent in both the sides. Then inspection for skin over the breast. Color and texture was normal on the right side. It was normal on the left side also. It was not red, warm, or edematous. Engorged veins were present over the chest wall and the breast, which was seen prominently on raising the arms. Dimple was absent on both sides. Pudy orange sign is positive on the left side, which gives rise to the typical orange peel appearance. Ulceration and fungation, the ulceroproliferative growth was present over the lump. The local examination for the ulceration and the fungation. The entire ulceroproliferative growth is about 7 cross 7 centimeters in size. The ulcer is 7 cross 5 centimeters in size. Ulceroproliferative growth is present in the upper outer quadrant over the lump on the left breast. The ulcer was having irregular margins, everted or rolled out edges. The slough was present on the floor with pale granulation tissue. Foul smelling discharge was serosanguinous in nature and was oozing out of the ulcer intermittently in small quantities.
Okay.
Then inspection of the nipple. Nipple presence, it was present on both sides. Position, slightly elevated in comparison to the right side. Number, it was solitary. One only was present. No accessory nipples were present. Size and shape, it was slightly more prominent than the right side. Surface, normal, no fissure, no crack or eczema on the left side as well as on the right side. There was no discharge from the nipple. Next, areola. Areola was inspected. First, the color, it was dark on both sides. Size, normal, about 2 centimeters in diameter. Number, it was 1. No accessory, areola is not there. Surface and texture, there was no fissure, cracks, ulcers or eczema in the areola. There was no discharge from the areola, sir. Then inspection of the other part. The arm was normal. No brawny edema, no thickened infiltration of the skin over the arm. The thorax was also normal. Abdomen was normal. No swelling or axilla was normal. No swelling was seen on inspection. Supraclavicular fossa also, no swelling was seen on inspection. And the examination was performed on asking the patient to raise her arms as well, so that we can reveal the lower surfaces of the breast if they were hidden while the patient was sitting. Next, palpation.
Okay, come to the first slide of inspection, man. First slide of inspection.
Okay, 1 second. Yes, sir.
The most important first thing to be done before starting our inspection is that we should get an informed consent from the patient after ensuring his privacy.
Okay.
Okay, first thing is that you should get an informed consent from the patient after ensuring their privacy and explaining them what they're going to do. Okay, that should be mentioned in the exam. so that the examiner can be impressed by your words. And the second thing is that after adequate exposure of the region you're going to examine is more important. Okay, these two things are to be mentioned before starting local examination. So inspection of breast is done in 3 positions. Initially, in sitting position with the hands on both sides, and next, patient in a supine position, and next with the patient in the hands upright position. And the fourth thing is that we should ask the patient to compress. Should ask the patient to have the hands on the hip and compress over. Okay, to give pressure on the hip.
Okay, sir.
So you mentioned about the position of the breast. Okay, first the initial thing that to be seen is that how the breast is, whether the both breasts are equal in shape and size. Okay, the left breast is slightly elevated. You have mentioned on the other side. Okay, than other side.
Yes.
That is a more important thing, is that we are localizing the lesion towards the left side.
Yes.
Okay. Next, ulceroproliferative lesion is present. Okay, it is present in the upper outer quadrant of size you have given around 10 cross 10 centimeter.
Sir,
For any ulcer,
7 is
yeah. Okay, man. Okay. For any ulcer, that should be a 3-dimensional measurement should be given.
Okay, sir.
Okay, 3-dimensional measurement is more important. And the absence of dimpling indicates there is no infiltration of the no infiltration of the fiber fatty tissues. Okay. Next slide. So here you're mentioning about the color and the texture of the breast. What is the importance of color and texture of the breast skin, man? If it is red, if it is completely erythema,
the possibility of infection over the breast, sir. Then
no, if there is erythema of the skin, what is the diagnosis, man?
Acute
there is no palpable mass. Okay. Other carcinoma which is associated with erythema. Whether any, Uday Lakshmi have answered it, man. Inflammatory carcinoma usually presents as erythema. Okay. There may be no mass palpable or no ulceration seen. Only erythema can be present. This is due to what is the reason for that, man? In inflammatory carcinoma, why there is just skin erythema, skin involvement alone is there? It will be a very painful condition. Why? Because there may be thromboembolic manifestations, man. The tumor can cause thromboembolus and which will affect the dermal capillaries. That can lead to erythema, stagnation of blood, erythema, inflammation, and pain. Okay. This is the importance of color and texture. Okay. So engorged veins. Next thing, what is the importance of engorged veins? Usually malignancy, Gayatri have answered. Yeah, Mounders disease. And the more important thing is that usually the vasculature of the tumor will be high. The tumors will have high vascularity. Okay. Then purity orange appearance. What is the mechanism behind purity orange appearance?
Sir, it is due to blockage of subcuticular lymphatics.
Named as in the name of the plexus, lymphatic plexus.
Sir, lymphatic plexus of.
Many are answering in the group, man. Sapis plexus. Okay.
Okay, sir.
Okay, man. So next slide. Next slide, man.
Yes, sir.
So here in the image you can see the ulcer on the upper outer quadrant, and here the nipple, and see the just images alone. The nipple areola complex is deviated towards the lateral aspect completely. Okay. Even the contour of the breast is completely altered. Here the ulcer does not involve just only the upper outer quadrant, it also extends towards the upper inner quadrant.
Okay, sir.
And there is a purity orange appearance in the lower inner quadrant, I suppose, with dimpling present, one in this image. You can see some dimpling in the lower inner quadrant even. Okay. So ulceroproliferative lesion. This depicts the involvement of skin. So
yes, sir.
In case of involvement of skin, it will be around. What will be the staging of the lesion, man? Tumor staging.
The T4B, sir.
Yeah, you're right. T4B. Okay. So from the inspection, if the skin involvement is there, it is T4B. What are the other skin involvements, man? Other than ulceration, what are the other manifestation of skin involvement? Other
Satellite nodules,
manifestations?
sir. Satellite nodules, sir.
Okay, satellite nodules.
Then pudgy orange appearance, sir.
Okay, purely orange appearance is not the skin involvement, man. Purely orange appearance is due to the involvement of Sapis plexus.
Yes, sir.
Okay, so satellite nodules, ulcers,
Okay, sir.
and what else, man? What other tests can be done here? Yeah, skin tethering is more important. Skin tethering, and
Okay.
what else you can see?
Skin fixation can be elicited in
Skin
palpation.
fixation. Okay, that
In
is in
palpation.
palpation. That is in palpation we can see about the skin. So other skin involvements like puckering, and Venkat have answered about it. Skin puckering and tethering is also a more important thing that is to be seen. Okay.
Okay.
If the ulcer involves nipple areolar complex, what is the disease called as? If there is an ulcer, yeah, Paget's disease of nipple. Okay. How to differentiate between Paget's disease of nipple from ulceroproliferative lesion? Paget's disease of nipple is a indicator of presence of some underlying malignancy. Okay.
Okay.
That is Paget's disease. How to differentiate between Paget's disease of nipple from ulceroproliferative lesion?
The Paget's disease, the nipple will be eroded and the nipple will be destroyed, sir.
Okay. First site of the lesion, man. It will be around the nipple area complex, and the ulceroproliferative lesion can be anywhere in the breast. Okay, first point. Second point will be in the ulceroproliferative lesion, infection can occur, and there may be some pus discharge or serous sanguineous discharges will be present. In case of Paget's disease of nipple, there won't be any discharge. Okay, there will be crusting present. In Paget's disease of nipple, crusting and scabbing will be there.
Okay, sir.
Okay, this is how we will differentiate between the Paget's disease of nipple and ulceroproliferative lesion. You should differentiate between the ulceroproliferative, ulcer proliferating. Here, Paget's disease of nipple is an erosion of nipple. Okay, erosion means it is destruction. Proliferation means it is growing up. Okay. So next slide.
Yes, sir.
Next, man. Coming to the nipple. Here, seeing the site of the nipple. Both nipples should be in equal position. Okay. But here the left nipple is not just elevated; it is also laterally displaced. Okay. What is the importance of accessory nipples, man? What are the other sites where you can find the accessory nipple? Sites of accessory nipple.
Sir, along the milk line.
Yeah, correct. Along the milk line on either side.
Okay.
Okay. Whether it is only for females or it can occur even in males.
Sir, it can occur in males also.
Yeah, it can occur in male also. So discharge from nipple. Okay. What kind of discharge are you expecting in case of malignancy, man? What kind of discharge can occur in malignancy?
Sir, blood can be there.
Bloody discharge. Okay. This is because of increased vascularity of tumor. Okay.
Yes, sir.
And what are the other discharges you can get from nipple? Other discharges you can get from nipple.
So greenish discharge.
Greenish discharge. Watery discharge. People are answering more. Green, watery. Milk. First thing is that milk. Okay, first discharge will be milk. Normal milk discharge can be there. That's whitish discharge, greenish discharge, black. Oh, okay. Any pus discharge can also be there, man.
Yes, sir.
Each and every discharge will depict some underlying condition. Greenish discharge is more commonly seen in duct ectasia. Pseudomonas and duct ectasia. What are the other conditions where bloody discharge will be present, man, other than malignancy? Other than malignancy, the bloody discharge can be seen in papilloma, duct papillomas.
Yes, sir.
Okay. So next slide.
Yes, sir.
Okay. So areola, nipple areola complex. So areola is always dark in color, and it is also involved in case of Paget's disease of nipple. Areola will also be involved.
Yes, sir.
The areola is normal. There's no fissures, no cracks, no ulceration. Is it okay? Next slide, man.
Yes. Infection with the other areas, sir.
Okay. So before inspecting other area, opposite side breast should also be detailedly explained, man. Detailedly explained.
Yes, sir.
Okay. And coming to the inspection of the other area, before coming to inspection of other area, we should also examine the patient in other positions like hands upraised position and with the hands in the hip compressing against the hip. Okay. Whether the swelling becomes prominent or not on inspection should be also mentioned to rule out the
Okay.
pectoralis muscle involvement, other muscle involvement. Okay. So of course,
Okay.
as I said, other area examination, arms is more important because lymphedema can occur when the axial lymph nodes are involved,
Yes, sir.
and the thoracic skin involvement and the chest wall involvement can be seen. In abdomen, what are you expecting, man?
Sir, liver metastasis is present. We will
On
be able to see.
inspection, what are you expecting in abdomen?
Oh, on inspection, swelling,
Any
sir.
mass in the abdomen can be visualized, man. Whether the mass is abdominopelvic or whether mass arises from the pelvis towards abdomen or from abdomen towards pelvis. Okay, like Ruckenbach's tumor. Okay, if it is a large Ruckenbach's tumor, it can be seen in an inspection as a pelvic mass. And instead of saying as a swelling, you can say as fullness of supraclavicular fossa, fullness in the axilla. Okay.
Okay, sir.
And here, examination of the infraclavicular region is also more important, just below the clavicle. Okay. And also suprascapular and subscapular region examination, back examination is also more important. Okay.
Okay, sir.
Okay. Next slide.
Yes, sir. Palpation, sir.
Continue, man.
Yes, sir. The normal side was first palpated, that is in this case the right side. Then the palpation was done using the palmar surface of the fingers with the hands flat, and the lump was detected in the left side. So the local temperature, it was afebrile on both sides. Tenderness, it was non-tender. Site of lump was in the upper outer quadrant, and size of number 10 cross 10 centimeters. It was solitary in nature, and margin was irregular. Surface and ulceroproliferative fungating mass was present above this lump, and consistency, the lump was stony hard. Fluctuation was negative and non-illumination was negative since it's not a cystic swelling. And fixity to the skin, it was fixed to the skin, it was fixed to the breast substance, but it was not fixed to the pectoralis major and not fixed to the serratus anterior, and fixity to the chest wall, not fixed to the chest wall. Nipple was normal, sir. Then palpation of the ulcer, the edge and margin, irregular margins, everted edges, that is rolled out.
So we'll complete wait 1 minute. We'll complete the palpation of the mass. Okay. We'll come back to the previous slide.
Yes, sir.
So next slide, man. So here the importance of consistency is more important. In case sometimes I see it can be a cystic consistency. So what is reckless disease? RECLUS, reckless disease. What is reckless disease, man? Reckless disease is nothing but intracystic malignancy. Intracystic papillaceous malignancies are called as reckless disease. There will be cystic lesion. Cyst means everybody know about the cyst, right? It is a mass that contains fluid in it, serious fluid in it. It will have a cystic consistency. There may be some papillaceous projections inside the cyst, which may be malignant. Okay. So consistency in this case will be cystic consistency. Though it is malignant disease, here the consistency will be cystic. Okay. So most commonly the malignant disease will have a hard, stony hard consistency. But in the case of reckless disease, it can be cystic in consistency. Okay.
Okay, sir.
So next is that mobility of the tumor within the breast tissue should be explained, man. So you didn't mention about the mobility of the mass, whether it is freely mobile or it is adherent to the underlying structure. Okay. You have given it as a 10 cross 10 centimeter. So it comes under T4B. Okay. Skin involvement is also present, right? So more than 5 centimeter with skin involvement, it is T4B.
Yes, sir.
So next slide, man. So if it is tender and warmth is present, you should rule out inflammatory carcinoma or secondary infection in the ulcer of ulcers. Okay. Secondary infection in the ulcer can also present with fever and increased localized increase in temperature, and tenderness can be present, man. Okay.
Okay.
Previous slide. Previous slide, man. Yeah. So fixity of the breast into the breast tissue. Okay. No, man. Next slide. Next slide.
Yes, sir. Yes, sir.
So if the mass is mobile inside the breast, what are the differential diagnoses? Let's forget about the ulcer of proliferative lesion. If there is a mass that is freely mobile inside the breast, it is most commonly likely to be a fibroadenoma. Fibroadenoma is also called as, because of its mobility, it is being given a breast mass is a fancy name that is given for it. Okay. So how to determine the fixity to the underlying fascia and muscle?
Sir, we can ask the patient to place her hand on her hip. Then we can check for the movement of the lump along the right angle, sir. And then the lump, if it is mobile in both the directions, like perpendicularly and sideways, then we can see that it's not under.
First thing that I mentioned is that instead of just telling like this, we can tell the patient, tell the examiner that we will just we'll see the mobility of the tumor after contracting the pectoralis major muscle. Okay. In inspection, if it is involving the pectoralis major muscle, on contracting it will become prominent. Okay. In palpation, the mobility will be restricted on contracting the pectoralis major muscle. So then when the examiner asks you how you will contract the pectoralis major muscle, you can go for this answer. That you will be asking the patient to keep the hands in the hip and compress over it. So how will you detect whether the pectoralis muscle are contracted? If you're asking a patient, you're asking an old lady.
Anterior fold of the axilla can be felt, sir. Anterior fold of the axilla, if the muscle is taut, it can be felt, sir.
Yeah, very good, man. The pectoralis major muscle forms the anterior axillary fold. While contracting the pectoralis major muscle, the anterior axillary fold will become prominent and taut. This is how you will clinically, objectively find that you have contracted the pectoralis major muscle. And we should mobilize we should move the mass in all directions, whether it is mobile or any one direction is restricted or not. Okay. This is how you will find the fixity of the mass in the posterior chest wall. Okay. Posterior retinal memory space. Okay. What does the chest wall fixity means, man? What does the chest wall fixity means? What are the components of chest wall? What are the structures of chest wall, man?
The pectoralis major, serratus anterior.
Okay, if the mass involves pectoralis major muscle, can you tell that it is fixed to chest wall?
No, sir.
Why?
Ribs, sternum.
Yeah. Pectoralis major and minor muscle is not a part of chest wall. Okay. Make it clear that even if the pectoralis major is involved or even pectoralis minor is involved, it does not that it is fixed to the chest wall. Only the intercostal muscles, rib cage involves the chest wall. Okay. Are components of chest wall. So fixity to the pectoralis major and the other pectoralis minor does not mean that the mass is fixed to the chest wall. So
Okay.
if even the pectoralis major muscle is involved, it comes under T4B.
Yes, sir.
Okay, if the skin is involved.
Okay.
If skin is not involved, it will be only T3. If there's no ulcerative lesion and the mass size is more than 10 centimeter and pectoralis major muscle is involved, it is only T3. Only when the rib cage and the intercostal muscles are involved, it will be considered to have a chest wall involvement and it will be considered as T4A.
Okay, sir.
Okay. Okay, man. Next.
The palpation of the ulcer. Edge and margin. The margin was irregular with everted or rolled out edges. It was tender. Marked induration was present in the base. That is, the base was hard. Depth of the ulcer was 5 mm. Bleeding. The ulcer was bleeding on touch. It was fixed to deeper structure, that is the best substance, and the surrounding skin, it was fixed to the skin.
Okay, next slide, man. This will be discussed under ulcer examination as a short case, man. Okay, next.
Okay. Sir, palpation of the axillary lymph node, among which the pectoral, brachial, subscapular, central, and apical groups of lymph nodes were palpated. Among which the central lymph nodes were felt, they were enlarged, 3 in number, they were mobile. The maximum size of the lymph node was 2 cross 2 centimeter, and the consistency of the lymph nodes was stony hard in nature, sir.
Okay.
And in cervical
lymph node should be mentioned as a 3-dimensional thing, man.
Okay, sir.
Measurement should be as a 3-dimensional thing because lymph nodes have 3-dimensional measurements, man. Okay. Next.
Okay, sir. Systemic examination. Respiratory system,
Yes.
normal vesicular breath sounds are heard on both sides. Cardiovascular system, S1, S2 was heard, no movement. Central nervous system, focal neurological deficit. Abdomen normal. External genitalia normal. Per rectal and per vaginal examination was also normal.
What is the importance of cardiovascular system in this one? Importance of cardiovascular system examination in CA breast is to rule out any pericardial involvement, man. Even the CA breast can metastasis to pericardium. It can cause pericarditis.
Okay.
So, in case of pericardial involvement, there may be some murmur present. Okay.
Okay.
Next slide.
Sir, the summary, sir.
Next, man. Go next. Coming to diagnosis, man.
Diagnosis: a 52-year-old postmenopausal female patient with a fungating growth in her left breast for the past 6 months, which is suggestive of a locally advanced breast cancer of the stage T4B N1 M0.
Okay, so we'll come to a short discussion for just 15 minutes, man, about general question that is commonly asked. What are the differential diagnoses for CA breast, man? Most common differential diagnosis for CA breast is?
Sir, acute mastitis.
Traumatic fat necrosis is the most common thing, man. Okay. Traumatic fat necrosis is the most common differential diagnosis for CA breast with mass. Okay.
Okay, sir.
Then the other things are antibiomass. Okay. Someone mentioned about inflammatory carcinoma. In inflammatory carcinoma, there may or may not be the swelling. Palpable swelling may or may not be present. Okay. So it cannot be considered as a differential diagnosis. So most common differential diagnosis for CA breast is traumatic fat necrosis. Okay. Then antibioma. What is antibioma, man? What is antibioma? In case of CA, breast abscess that is being treated by antibiotic and not drained properly, the abscess, the pus gets organized and forms a solid swelling. Okay, this is called as antibioma. It is also called as sterile abscess. Okay, this can also mimic the CA breast. And fibroadenosis. Okay, fibroadenosis are sheet-like structures. Okay, man. That is also due to the menstrual. Due to the menstrual changes, it can occur. The age group will vary, man. That is how you have to differentiate. Okay. So, what is the order of palpation of axial lymph node, man? In what order you will be palpating the axial lymph nodes? What will be your position in palpating the axillary lymph nodes?
Sitting position, sir.
Yeah. First, whenever the examiner asks you about how you will examine, first thing you have to tell is that after explaining the procedure to the patient and getting informed consent and adequately exposing the area, I'll go for examination. Here, the examination should be done while in case of a lymph node examination, for examining the axilla, the examiner should stand in front of the patient with the patient's arm over his arm. Okay. The first thing that we are supposed to examine central group of lymph nodes. It will be easily examined. Okay. The axial lymph node can be classified as lateral group, anterior group, posterior, and central and apical group, man. Okay. This is how you will differentiate differentiate the axillary lymph node and will examine the lateral, anterior, apical, central, and posterior lymph nodes. Okay. Then we will examine the subscapular and supraclavicular and intraclavicular lymph nodes should also be examined. Okay. For examining the subscapular and posterior group of lymph nodes, you should stand behind the patient. That is the more important thing. Okay. Other lymph node examination, the examiner should stand in front of the patient. While examining the subscapular lymph node, the patient should be behind the. The examiner should be behind the patient. Okay.
Okay.
So, what is the investigation you will advise for this patient, man?
Sir, investigations. The first investigation.
For any CA breast.
Yes, sir. So to identify, we can use mammogram, sir. Other than that, to confirm the diagnosis, biopsy and incisional biopsy from the head. To state diagnosis, we can do a PET-CT or a positron emission tomography CT scan. And to treat the patient, we can do the routine pre-anesthetic medication and surgery.
Thing is that you should answer as triple assessment, man.
Okay, sir.
Okay, what are the components of triple assessment? Triple assessment is a topic. It's an important question for you, man. It involves clinical examination, first thing. Second thing, radiological investigations. Third thing is that histological examination. Okay. So clinical examination is the first component. Second component of triple assessment is radiological investigation. Third thing is that histological examination. Okay. So here, as I usually advise my juniors to go for investigation in 3 ways. One, for a surgery case, first investigations towards diagnosis. Second thing is investigation towards anesthesia assessment, like improving the general condition of the patient and identifying any systemic abnormalities there, like diabetic, hypertensive. Third thing is that investigation towards other problems like metastasis. So the first thing, as everybody has mentioned, radiological examination is mostly done. Okay, first thing. Why the radiological investigations should precede the histological examination, man? Whether I can go for an incisional biopsy and then I can go for a ultrasound or a mammogram.
Sir, to guide the.
It's okay, I'll come to this question later. To whom you will prefer mammogram and to whom you will prefer ultrasound? People are answering. For younger people, you will go for ultrasound, and in older people, you will go for mammogram. Okay, because of density of breast will be more in case of younger people, so we are going for ultrasound. In older people, the density of breast will be less, so you can go for mammogram. In case high risk group are there, BRCA 1 mutation, 2 mutation people will be there, and patients who have already operated for some lumpectomy, some scar in the breast, or someone like have done some augmentation surgeries in the breast. For those people, we should go for MRI. Okay. This is the investigation to be done. That is radiological investigation. So here, while you are talking about or discussing about radiological investigation, Birat's classification is more important, man.
Okay, sir.
So can you tell me the Birat's classification, man?
Sir, 0, 1, 2, 3, 4, 5, 6. Sir, 0 is if it is incomplete. That is, if the thing is cloudy
You should go
and
for
we are
other
unable
modality
to.
of investigation.
One, okay, sir. One is
Okay.
if mammogram is negative. Two is mammogram is normal with no apparent cancer. Three, that there is approximately 2% chance of cancer. 4, 20 to 35% chance of cancer. 5, 95% cancer. 6 is that if it's already been diagnosed as breast cancer, that is pathologist has confirmed the diagnosis.
Okay, BRAF 0 means you should go for this modality. This investigation modality is not sufficient. You should go for other modality of treatment. Investigations. BRAF 1 is that is nothing. BRAF 2 is benign. 2 is benign. 3 is that it is probably benign. 4 is that is high suspicious of malignancy. 5 is that it is highly suspicious of malignancy. And 6 is that it is already a pathologically proven thing. Okay, this is the BRAF classification. So abbreviation for BRAF is hello. Yeah, abbreviation for BRAF, man. Can anybody mention about it? BRAF abbreviation. Yeah, Mritula answered it. Breast imaging and reporting and data system. Okay. Okay, man. So after the radiological investigation, what are other radiological investigation you will suggest, man? I can go for bone scan. Okay. Ultrasound abdomen for ruling out abdominal metastasis, any hollow organ metastasis, and the CT chest for ruling out any to detect the posterior extent of the tumor, and also to detect the lung involvement and chest wall involvement, and bone scan. Complete skeletal survey with the X-ray can be done to detect any bony metastasis. These are all the investigation towards diagnosing the metastasis. So what are the investigation towards metastasis means? First thing is that ultrasound abdomen to rule out any liver metastasis or any other organ metastasis, or even a Krukenberg's tumor can be detected by ultrasound. And ultrasound axilla should also be done to detect any axial lymph nodes, and the opposite side axilla should also be seen. And X-ray of the whole body, that is skeletal survey, should be done. Instead of doing all this, you can go for even PET scan. Okay, whole body PET can be done. Okay, instead of doing all these investigations, you can go for single modality of investigation of CT. PET CT. Okay, next man, what can be done? And the more important question is that another important question is that what are the features of malignancy in mammogram? Okay. Yesterday I told about it, I suppose. There will be a video in YouTube. You can go through it, man. What are the features, mammographic features in malignancy is also an important question. Okay. Then what else it can be done?
The treatment like neoadjuvant chemotherapy,
What are the indications for MRI, man? List out the indications for MRI. Breast implants, recurrence, then high risk people, previous surgery, and very good pregnancy have been informed that okay, pregnancy is the most important situation where we will go for MRI. Okay, because we cannot go for other investigations. Even PET cannot be taken in case of pregnancy. We should go for MRI. Okay, then we will go for histological examination. First modality of treatment will be FNAC, fine needle aspiration cytology. Okay, what size of needle should be used for FNAC is that 22 or 23 gauge needles should be used. Very good, answered correctly. 22 or 23 gauge needles should be used. Here, a minimum of 6 passes should be done. The needle should be passed inside the tumor at least minimum 6 times. Okay. So, what staining can be done, man? What are the stains that are commonly used in cytological examination? Can anybody? Yeah, isofine blue. Oh, not technician. The pencil which you used in your first year physiology. Methylene blue can be used, and eosin and hematoxin can be used. Okay. So, in case of FNAC, what is the drawback in FNAC? FNAC cannot differentiate. I can get you, man.
Invasive carcinoma and ductal carcinoma in situ cannot be distinguished.
Yes, it cannot be differentiated between invasive and in situ carcinomas. Okay. In that case, another thing is that it cannot determine the receptor status. It cannot be used for mentioning the receptor status. So for these conditions, with these situations, we will be going for core needle biopsy, also called as true cut biopsy. Okay. So what will be the procedure for true cut biopsy? In true cut biopsy, we will be using a local anesthesia, and an incision will be made. Okay. Here the more important thing is that the incision made for the taking a true cut biopsy should be enclosed and should be removed during the surgery, because the incision we make while taking true cut biopsy can form a scar. From scar, recurrence of tumor is more possible. Even after doing a MRM, the CA breast can recur from the scar from where we took out true cut biopsy. So always, while taking a true cut biopsy, you should consider about the future incision of the MRM, and the incision should be included within the incision for MRM. So okay. So that is how you should decide the incision where to take a true cut biopsy. Okay. So here a true cut gun will be there. Separate gun will be there. Incision will be made with a 11 blade, and the true cut gun will be inserted, and the mass will be fixed, and then the shooting will be done. And here the advantage of the true cut biopsy is that it can be used for detecting the invasive or in situ carcinoma, and also for receptor status. Okay. If the tumor is less than 2 cm, whether we can go for a true cut biopsy or what can be done. If the lesion is less than 2 cm. If the lesion is less than 2 cm, you can go for excision biopsy. Okay. We can remove the entire mass. Okay. We need not go for true cut or FNAC in case the tumor is less than 2 cm. If that is T1 lesion. Okay. And then we can go for, we can send a specimen for histological or pathological examination. When the lesion is more than 2 cm, you can go for FNAC. If FNAC is inconclusive, we can go for true cut biopsy. If FNAC is inconclusive, how many times you can repeat FNAC, man? You can repeat the FNAC for 3 times at least. Okay. So what is incisional biopsy? What is incisional biopsy? If the mass is very big and even the true cut is inconclusive, we can incise, and we can make an incision, we can explore the lesion, and we can take a part of the lesion under vision and send it for pathological examination. Okay. This is usually done before starting any palliative treatments. So next, what are the other methods for taking biopsy are image guided biopsy, man. Like ultrasound guided biopsy. Nowadays, mammogram guided biopsy, even MRI CT guided biopsy, MRI guided biopsy, and vacuum assisted biopsy is also there. These are newer things. Stereotactic vacuum assisted biopsy. Here, the images will be guiding you for taking the biopsy. Okay. So in biopsy, what are the things you are going to notice? First thing is that the pathologist will be reporting you about the grading of the tumor. As yesterday we read about the Scarf-Bloom-Richardson classification, grade 1, 2, 3, well differentiated, moderately differentiated, and poorly differentiated. So grading of the tumor will be mentioned. Mitotic index, Ki67 will be mentioned, and the nature of the cell will be mentioned. Okay, these 3 things are more important in determining the prognosis of the disease. Okay. And also the hormonal status, hormonal receptor status is also more important, as I mentioned. Okay. So next, what we'll be doing, man? Next thing will be, after confirming the disease. So in this case, in your case, what you will be doing, man? Whether you go for FNAC or true cut biopsy, what you will be doing?
True cut biopsy can be done, sir, or can be done, sir.
Preferably true cut biopsy can be done, and I will go with the FNAC of the lymph node if it is palpable. In case of axilla, I will examine the both axillars. If any node is positive, I will go for FNAC of the node. Why I am going for FNAC of the node is that here you have an ulceroproliferative lesion. Okay, the ulceroproliferative lesion are more. You mean ulcer. You know about the definition of ulcer now. Epithelium is breached, right? So it is more prone for infection. So secondary infection is more possible in case of ulcers, and this can lead to reactive lymph node enlargement. More than metastasis, reactive lymph node enlargement can also be seen. So to rule out the reactive or it is a metastasis, we should go for FNAC from the node. Okay, this can also be done, but the maximum chance it is a T4B, there will be increased risk of metastasis is more common one. So it is not much necessary to take the FNAC, but taking FNAC is not an issue. Okay, then what else we will do? We will diagnose it to have a invasive ductal carcinoma or what else? Invasive lobular carcinoma. What you will do, man? Whether invasive lobular carcinoma in situ. What does mean by lobular carcinoma in situ, man?
That is, the cancer hasn't invaded the stroma.
The entity is that lobular carcinoma in situ is itself is not a cancerous situation. It is not even a precancerous situation. Okay, it is not even a precancerous situation. It is considered to be an indicator. Okay, lobular carcinoma in situ is an indicator, and the most common cancer that can arise from lobular carcinoma in situ is, what is it, man? Lobular carcinoma in situ can develop as 80% as invasive ductal carcinoma. Know the point, man? Lobular carcinoma in situ can arise and can develop into ductal carcinoma. I mean invasive ductal carcinoma than invasive lobular carcinoma. Only 20% develop into invasive lobular carcinoma. And the lobular carcinoma in situ is indicator of increased risk of CA breast. Okay, increased risk of developing CA breast on either side, either breast. So if you are detecting any case of, if a pathologist is reporting you as a lobular carcinoma in situ, you should go for prophylactic mastectomy, or you should go for at least chemotherapy, prophylactic chemotherapies. So the most important thing I want to tell you is that lobular carcinoma in situ is not a cancerous condition. Okay, it's not a cancerous condition. It is an indicator of cancerous condition which can develop in near future. The most common cancerous condition that arises after lobular carcinoma in situ is invasive ductal carcinoma. Okay, it is an invasive ductal carcinoma that arises from lobular carcinoma in situ. There is a point you should note. Okay. So what will be the stage of your disease, ma'am? T4?
T4B, sir. T4B, N1, M0.
N1. What do you mean by N1?
Sir, N1 is involvement of level 2 or level 1 to axillary lymph node, sir.
N1 means it is just the involvement of same side mobile node. Okay. Ipsilateral, same side mobile axial lymph node involvement is considered to be N1. If it is fixed, it is N2. Okay. So here you mean that it is a N1 with the M0, right?
Yes.
So what are the stages of classification, you know, man? So which stage it comes under? T4B, N1, M0 comes under?
Sir, 3.
Any T4 will come under 3B.
3.
Okay. Yeah, 3B. 3B means it is a locally advanced cancer.
Yes, sir.
It is a locally advanced cancer. So what will be your treatment modality for this patient?
Sir, neoadjuvant chemotherapy followed by modified radical mastectomy, and then
preferred regimen for this patient is preferred chemotherapy regimen for this patient is? CMF regimen is preferred, man. CMF means cyclophosphamide, methotrexate, and 3-fluorouracil.
Okay.
Okay. CMF is preferred. Okay, cyclophosphamide, methotrexate, and 5-fluorouracil. And the second preferred regimen is, as mentioned, CAF regimen. Cyclophosphamide, adriamycin, and 5-fluorouracil. Okay. What are the complications of using cyclophosphamide, man? Most common complication of using cyclophosphamide. Yeah. Someone answered it in the group as hemorrhagic cystitis. What will be the treatment for hemorrhagic cystitis? Yeah, MESNA. So while we are going with the cyclophosphamide, we should also give MESNA for the patient to prevent hemorrhagic cystitis. Okay. What is the complication of using methotrexate, man? Any idea? Methotrexate toxicity. So it will lead to bone marrow suppression. This can be prevented by giving folic acid. Okay. So usually the methotrexate should be advocated with leucovorin or folic acid. Okay. Okay. So we are given neoadjuvant chemotherapy for this patient. Then how we will classify the patient based on the response of the neoadjuvant chemotherapy, man? So based on the response, okay. So first thing is that how we will identify the response, how we will monitor the response. What is the investigation of choice to monitor the response of neoadjuvant chemotherapy? MRI is the investigation of choice, man. Okay. MRI is the investigation of choice to monitor the response to the prophylactic or neoadjuvant chemotherapy. So based on the response, based on the MRI findings, we can classify the patient as with good response, poor response, or not responding people. Okay. So for good response, you can classify the patient as into 4 groups, man. Completely So these are the classification based on the MRI findings in post. So after downstaging the disease, this procedure can be called as downstaging of the tumor. So after downstaging of the tumor, you can go for surgery. You will go for surgery. Here in this case, the entire mass should be removed and clearance of at least 2 centimeters should be given. Okay, from the lesion, at least 2 centimeters should be given, along with axillary dissection. Okay, what are the components of MRM, man? MRM includes. Can you hear me, man? MRM includes total mastectomy.
Mastectomy, axillary tail can be removed, sir, along with axillary lymph nodes. Pectoralis major must be preserved, sir. Pectoralis minor is.
What are the modifications in what are types of MRM that you know, man?
Patty's modification, Hanlon modification,
okay.
Auchincloss modification.
So what we commonly do? We commonly do Auchincloss, man.
Okay, sir.
So what does Auchincloss MRM means? What is the important feature of it?
So pectoralis minor is retracted, but it's not divided.
Okay. In Patty's.
The pectoralis minor muscle is removed, sir.
Okay. In other things, Scanlons?
In Scanlon, pectoralis minor muscle is divided, sir, but not retracted.
Okay. So based on the pectoralis minor, we are doing this. Why we are concerned with the pectoralis minor, man?
Sir, to clear the axillary lymph nodes, sir. Axillary.
Which level?
Level 2,
surgically, the axial lymph nodes are divided into level 1, 2, and 3 by the pectoralis minor muscle, man. Okay, just in the inferior aspect of pectoralis minor, there will be level 1, and just behind the pectoralis minor, level 2, and above it, level 3. Okay. So to see the level 2 lymph nodes, we are supposed to remove or retract the pectoralis minor.
Okay.
So MRM is done for this patient. Then what are the borders of, what are the boundaries of MRM, man? Mastectomy. Mastectomy boundaries of MRM. Superiorly, we will raise the flap up to. Superiorly, for mastectomy, no, people are answering about the axillary vein. It is not. That is for axillary dissection. Okay, I'm asking about mastectomy. Yeah, superior flap should be raised up to clavicle, inferiorly up to 6th or 7th rib, and medially up to the lateral border of the sternum, and laterally up to the lateral border of the latissimus dorsi. Okay, can you get it clearly, man?
Yes, sir.
Superior flap should be raised up to clavicle, inferiorly 6th and 7th rib, and medially up to the lateral border of the sternum, and laterally up to the latissimus dorsi. So, what are the boundaries of axillary dissection, man? Boundaries of axillary dissection. Well, yeah, superiorly axillary vein, then superiorly axillary vein, inferiorly angular vein, medially, superiorly it is axillary vein, inferiorly it is angular vein. What are the medial and lateral boundaries of axillary dissection? What are the medial and lateral boundaries, man? It is serratus anterior and latissimus dorsi vein. Okay. So superiorly it is a axillary vein, inferiorly it is a angular vein. Okay. What are the complications of axillary dissection? What are the expected adverent complications of axillary dissection? It is lymphedema, then
Arm movement limitation can be there, sir.
yeah, lateral thoracic, nerve injury, hemorrhage, bleeding. Yeah. What is lymphosarcoma? Lymphedema, nerve injuries, neurovascular bundle injury, hemorrhage, thromboembolic manifestation can also occur. Okay. These are the complications of axillary dissection. Okay. Lymphedema, nerve injury, hemorrhage can occur, severe bleeding can occur because there may be some dead space created because of removal of the nodes. Okay. So extra point. On an average Indian male, how many axillary lymph nodes will be there, man? Approximately, how many axillary lymph nodes will be there? It won't be asked probably. It's a fantasy question for many examiners. There will be around 53 nodes, man. Averagely, an Indian man can have 53 axillary lymph nodes. Similarly, around 3 to 4 internal mammary lymph nodes on average. It can vary in number. So you have done these things. Okay, you have done an MRM for this patient. So followed by MRM, you should complete your chemotherapy. Okay, you have started neoadjuvant chemotherapy preoperatively. After 3 cycles, you are downstaging the tumor and you are going for MRM. Followed by, again you will be followed by post-operative chemotherapy. And we should go for frozen section study of the specimen to find whether the entire tumor is enclosed in the specimen. If you are suspecting any residual lesion, we should go for radiotherapy. If you are suspecting any residual lesion, or if the specimen has a positive tumor margin, if the margin of the specimen has positive for tumor cells, we should go for radiotherapy. So, radiotherapy is to eliminate the localized disease. Okay. Radiotherapy is to eliminate the localized disease, while the chemotherapy is to eradicate the systemic disease. There are 2 concepts, man. Initially, Halstead's concept. Okay. Halstead, you know about William Halsted, right? According to him, according to his concept, he thought that the CA breast, the disease will lie in the breast tissue alone for few months, and then it will spread to the axilla, and there it will lie for few months, and then it spreads. So he advised aggressive treatment in the breast and the axilla can help curing the disease. So he devised a method called as loco-regional aggressive disease management. But this was proven as this was not useful. So next comes the Fisher's theory. So as per Halstead, the disease lies only in the breast for few months, and then it will go for axilla, and there it lies for few months, and then it will go for systemic spread. So he advocated for a local regional approach to eradicate the disease. But Fisher, he told that even a 1 centimeter tumor in the breast will lead to micro-invasion. So CA breast is a systemic disease. So every CA breast should be treated with chemotherapy. That is what he advocated. So what Fisher's theory says that even a 1 centimeter tumor will lead to micro-invasion. And hence the invasion and metastasis starts as early as possible. So any tumor should be given with chemotherapy. More than 1 centimeter tumor should be given with chemotherapy. Okay, this chemotherapy can be individualized. Okay, so chemotherapy is for systemic disease. Okay, so for systemic elimination of the disease, and radiotherapy is for localized elimination of disease. And if in case of BRCA1 mutation, we are going for a mastectomy, we have one more systemic treatment modality, that is endocrine treatment. Okay, endocrine therapy, where we will use our receptor modifiers. Okay, we have some receptor modifiers like selective estrogen receptor modifiers like tamoxifen, raloxifene, and aromatase inhibitors like letrozole. So what are the mechanism, man? This tamoxifen will have an antagonistic effect on estrogen receptor in breast, but it will have an agonistic action in the other areas. Okay, extramammary estrogen receptors will have an agonistic effect by tamoxifen, while the estrogen receptors in the breast will have antagonistic effect. So doing a prophylactic mastectomy in one side and giving tamoxifen will have a protective effect on the opposite side. Or if any patient diagnosed to have a high risk factor for developing CA breast, you can go for tamoxifen, which is a selective estrogen receptor modifier. Okay, it will have an antagonistic effect on the estrogen receptor in the breast, while it will have an agonistic effect on the other extramammary estrogen receptors. So what will be the complication? It can lead to menstrual irregularities, and endocrine cancer can occur. Endometrial cancer can occur in this case, because the estrogen receptor in the endometrium will be stimulated a lot by tamoxifen. So prolonged use of tamoxifen is also not advocated. So this selective estrogen receptor modifiers are advised for premenopausal women. What you will do in case of postmenopausal women? Here, we will go for aromatase inhibitors. In postmenopausal women, the main source of estrogen is androgens, that is produced by adrenal gland. These androgens will be converted into estrogen by aromatase enzyme. So here our aim should be to prevent the conversion of the androgen to estrogen by aromatase. So we will go for aromatase inhibitors like letrozole. This is advocated in postmenopausal women. Okay, this both includes the endocrine therapy. This is used for preventing the CA breast in the opposite side, and also helps in preventing the recurrence. Okay, so we have learned about two systemic therapies and one localized therapy and MRM for eliminating the complete disease. So again, you will be reading about some specialized condition like pregnancy. So in case a pregnant woman coming with CA breast, what you are expecting? Usually, in case of pregnant women, they will be presenting to us in the later stages only because of the physiological changes in the breast. The CA breast will be masked. The CA breast features will be masked by physiological changes in the breast. So usually these patients will present with severe stages. Present at later stages. So you can have a question that whether the therapeutic abortion is indicated in this case. If a pregnant woman comes with a CA breast, whether you can go for aborting? No, not necessarily. Okay, pregnant woman with CA breast, not necessarily it will be aborted. Abortion is indicated only when the disease is very severe, where we are supposed to go for aggressive management with radiotherapy. Else you can wait. The mainstay of treatment in pregnancy will be surgery, because radiotherapy is not advised in case of pregnancy. Okay. Also, chemotherapy is also not advised because chemotherapy drugs will have teratogenic effect on the baby. So, considering these two factors, MRM, any surgery is the treatment of choice for CA breast in pregnancy. Even the endocrine therapies like selective estrogen receptor modifiers and aromatase inhibitors are avoided, considering its teratogenic effect. Okay, and radiotherapy and chemotherapy can be advocated after delivery. A patient comes at second or third month. That is first trimester. Surgery is the treatment of choice. In some books, they have stated that even chemotherapy can be started after the first trimester. Only in the first trimester, we should not start chemotherapy. Is being given in some books, but standard book says that only the surgery is a treatment of choice. Only after delivery or therapeutic abortion, we can go for chemotherapy or radiotherapy. Till that, we have to wait, and then you have to go for localized irradiation, and lactation should also be deferred. Breastfeeding should also be deferred in these cases. Okay. Breastfeeding should be deferred when the patient is taking hormonal therapy or radiotherapy or any chemotherapy drugs, because these drugs have their own toxicity, like Methotrexate bone marrow suppression and the cardiotoxicity in case of doxorubicin. This can be transmitted even to the babies. So chemotherapy should be, while the patient is on chemotherapy, breastfeeding should be avoided. This is a special condition, special situation, and the investigation of choice in case of pregnancy is MRI, man. Okay. Whether other CT can be taken. Whether CT or X-ray chest can be taken. Yes, it can be taken. Yes, it can be taken by using abdominal guard. Okay, we have a specialized instrument called as abdominal guard, which prevents the radiation entry into the abdomen. Okay. Yeah, that contains heavy lead metals. Okay. With abdominal shield or abdominal guard, if much necessary, you can go for CT. Okay. So you have to read about the importance of CT, advantages of CT over MRI. MRI is the investigation of choice, but there are certain advantages in CT than MRI. Just go and read about it, and we will just complete the session by now because it is too late for you people. Any doubts, you can call me at any time. And it is an elaborate big topic, man. We can't complete it by just a single session or anything. Okay, probably I think you'd have got some idea about case presentation, how to present. And I don't think this is not a format of case presentation, man. I have just explained you the thing, and I have just taught you about how to take questions, how to answer the questions. Okay, what are the possible questions that can be asked is what we discussed. Okay, so the presentation will be very, the questions will be very even more difficult for you people. So you have to learn more. Start reading, keep reading. Any doubts, you can ask me. Okay, surgery is a field which is a more innovative field, man. Even you can become a pioneer in surgery. Even you can become a pioneer in surgery. You can devise your own technique of surgeries. This is how the surgery has evolved. Halsted, you know about Halsted, that he had removed everything. Recluse, major, minor, everything he has done. Okay. And one more thing I have to tell about you is that you should read about the types of mastectomy, man. Simple mastectomy, radical, even super radical mastectomy are there. You have to read about it also. So this is not a complete class. There are many things to be discussed. If people start reading, if time permits, we'll meet again. And any doubts regarding CFS, you can message me personally. I'll give my number here. Okay. So hope it will be useful for you people. And thank you, man. Thank you.